Thank you very much to CEDA and to Kyle for the opportunity to speak to you today on a PowerPoint that should come up very soon. There it is. On the Holy Grail of health service integration, a view from the field. So one of these Australians has very episodic contact with the healthcare system and requires very little special connectivity. The other has an absolute critical need for effective teamwork, high quality information sharing and confidence that everything important in her care is being done. I'm going to start with a statement of the status quo. Changes in the community's health needs and in healthcare practice demand corresponding changes to the structure and incentives for Australia's healthcare system. An increasing prevalence of chronic health conditions requires more emphasis on ongoing care across services, a consistent reduction in lengths of stay, an expanded use of non-inpatient and ambulatory care challenge the historical separation of hospital and community, and there are pressures for improved productivity and efficiency in the delivery of healthcare. The following are the desirable features of a well-integrated health system: incentives for best practice care and for productivity and efficiency, scope for substitutability and flexibility, service models which encourage continuity of care, and at the bottom, clear roles, responsibilities and accountability between levels of government. So before you fall asleep post-lunch, I'm going to ask for a show of hands. Who thinks that quotation comes from the Council of Australian Government's April statement this year? Okay, who thinks it comes from the Primary Healthcare Advisory Council report to Minister Lee last December? Who thinks it comes from the Primary Healthcare Strategic Framework signed by Minister Plibersek and all state and territory health ministers in 2013? Who thinks it comes from the National Health and Reform Commission report mapping out Australia's healthcare system 2020? It's a very informed audience, they told me this. And who thinks it's the communique from the Special Premiers Conference not far from this point in 1990? And sadly, you are correct. So my topic today is really twofold. If we've known so much about the problems and the challenges and the likely impacts of changes in healthcare and the importance of service integration, why is it such a challenge, and why have we made so little progress, and what can we do about it? And the problem in this country is that we've made very, very coherent observations around the problems. We talked a lot about them. We've reported them. We have tomes of different reports and recommendations. But as a country, we tinker and we pilot, and we never get around to mainstreaming. And when I look at the 30-year journey that this country has been undertaking and compare it with undertakings in other countries, we'll see that the National Health Strategy first mapped out the approach in 1991. They created divisions of general practice, which were then folded, and new Medicare locals were announced, and they were then folded, and primary health networks were commenced 2 years ago as an opportunity to build a momentum and integration around primary care. We've had at state level across the country and nationally millions of dollars going into high-level, high-quality integration initiatives. We've had a national support evaluation and research unit. We've had divisions of general practice and hospitals all over the country hurling themselves into activity here. And we've had a lot of policy-level discussion and recommendation. And as Tim said, we put $1 billion into e-connectivity. I'd like to start 30 years ago when the Sisters of Mercy were doing a lot of heavy lifting during the HIV/AIDS pandemic. They were doing a lot of work in the community with hospices and home care, and to their horror they realised that the community and the hospital service delivery had completely lost contact and were fractionated to the point where it was causing serious impact to their patients. So being the sisters, they decided to do something about it. And they set up our centre, which was then the very first integration centre nationally, and it had 3 missions. First of all, it needed to strip down all the best evidence internationally and create some really good new integrated pathways. It then needed to provide high-quality evaluations such that there could be publications nationally, internationally around those approaches. And finally, we needed to be teaching both at undergraduate and postgraduate level around those models of care to improve the future. And we hurled ourselves enthusiastically into that with a lot of fantastic managers and clinicians at state, local and national level. We combined to create a myriad of integrated clinical models of care, integrated IT systems where we electronically generated discharge referrals to thousands of clinicians around the Mater and received e-referrals back from them into outpatients. We created multidisciplinary interprofessional training across the continuum. We ran hospital in the home programs. We ran conferences. We wrote books. We prepared workshops which we ran locally and at state at national level. And when we turned around in 2005, we realised there was very little left standing. Apart from some of the initiatives that the Mater had committed to, the others were pockets of enthusiasts in small areas of the country, and very many of them had died away. And so we set about for the next 10 years working out why. And our national integration initiatives are unsustainable for 4 very good reasons. First of all, we have 2 levels of government with very disparate business rules, requirements and frameworks. We have funding mechanisms which have state-funded rules and responsibilities, Commonwealth-funded rules and responsibilities, and locally we have both sets of government providing services and funding services, but also we have funding from private health insurers, from small businesses, both in primary and secondary care, from NGOs, and also from individuals and families. And at a local level, it is a complete mess. We also have a complete separation of those providing care who have good ideas for opportunities and challenges with those setting the policy framework who do that from the helicopter. And we have a siloed culture where we deliver the absolute best to patients within our organisations or practices, but when you step out over the doorstep, you're someone else's problem. Before you start reaching for your Prozac with lunch, we have some real opportunities, but they will not materialise unless we name the past and seriously focus on a future that addresses the very many challenges I've detailed. First of all, we've got an awesome amount of reform activity happening, and it is for the first time being integrated, and there are a lot of very good ideas and policy initiatives currently prevalent. NIPA, before it was finished in June, charted out in a very clear way the huge gaps, the fragmentation, the appalling care that occurs in very many parts of the country with the 1 million Australians with the most complex, needy, chronic health needs, seeing on average 5 different general practitioners in a year, and hospitals across the public and private sector having a massive variation in their ability to prevent hospitalisation. State governments all are facing burning platforms concerning resourcing, the growing need for complex chronic support. We now have 31 primary health networks, however, who have bipartisan support. They now have the critical mass and imprimatur to really make a difference. And everyone else in the OECD is really doing this. And as Tim said, the states, which we've laughed at for such a long time, is really kicking some home runs at the moment. The Council of Australian Government made some groundbreaking announcements and progress in April this year, which I'll talk to in a moment. And we also have a lot of fantastic new linkage tools clinically and across governance that are really going to help. So what did the Council of Australian Government say in April? The Prime Minister and all premiers committed to bilateral agreements to provide flexibility for each jurisdiction to determine the best model of care for the 10% of Australians who consume 50% of chronic disease resources in this country. The Commonwealth would establish the enabling infrastructure, governance arrangements and systems to support a pilot of healthcare homes, which I'll talk about in a moment, and also the funding levels and levers and payment mechanisms in Commonwealth-funded services. The state, in return, committed to joint coordinated planning and, where appropriate, collaborative commissioning of services between the primary health networks and local hospital networks, and, where feasible, to implement collaborative, joint and/or pooled funding between primary health networks and local hospital networks to support better coordination of care for specific patients at risk of avoidable admission. The healthcare pilots almost been announced 5 times, but we understand the Prime Minister and Health Minister are preparing this week to announce pilots for 65,000 Australians with chronic disease across 200 practices Australia-wide, based within 7 to maybe 10 primary health networks. The healthcare home model is modelled on a successful US family practice model, the patient-centred medical home, which has had extraordinary evaluation over the last 6 years. Much improved clinical outcomes, much improved patient and health provider satisfaction, and much improved clinical efficiency, with an implementation of a much better integrated model based around primary care. The National Health and Hospitals Reform Commission first noted this. The College of General Practitioners, in their vision statement last year for a sustainable general practice sector within a sustainable healthcare service, identified this as their benchmark for the future. And we've had the incredible privilege, as our Centre for Research Excellence, working with some of the doyens in this area to Aussieise PCMH and lay it within the Australian healthcare and reform environment currently. What are the key elements of the healthcare home, without which we will create a healthcare cubby house? The first one is patient enrolment or empanelment. In our setting, this will be voluntary, where those 65,000 Australians will be offered a voluntary linkage with one general practice or healthcare home that will provide all their chronic disease management. And in return for that, they and their patients and families will become true partners in care with that practice. They'll have enhanced access to care, so not only will they have face-to-face care, but they will be able to access email, phone, text, and potentially video conferencing from their healthcare home, and expedited in-hours and after-hours access to the team. They will nominate a preferred clinician who will be responsible and accountable for their care, leading a team within the practice, wrapped around with the team within the community in health and social care, and within reach from those clinicians in secondary care that are critical to their high quality and safe outcomes. And that will all be informed by appropriate data to improve the incomes, and an all of practice, all of systems, let's build our performance mentality. That can only happen with changes in payment funding, from the current episodic MBS funding to a blended payment across the 12 months. Queensland Government has really thrown itself behind the integration initiative, particularly over the last 18 months, and the Queensland Clinical Senate has taken better integrated care very much to heart for this year in 2017. They are progressing that work with a fantastic best practice tool that Carolyn Nicholson developed last year as part of her PhD, where she stripped down all the successful primary-secondary integration initiatives internationally, loaded them into 10 key elements, and created a balanced scorecard approach, which is now being used by primary health networks and health and hospital services across Queensland to document the key initiatives they want to undertake, the way they're going to measure them, and what the outcomes will be. And from a local perspective, our primary health network has been working very hard to progress the major integration initiatives that we have been working upon since our division of general practice time, our Medicare local time, and now as a primary health network. And we are one of very few areas in the country that have got that 20-year corporate memory and ability to lever off the wonderful work that has been done over a long period of time. Our Team Care program wraps experienced care coordinators around general practices throughout our geography and works with those practices to build in social and healthcare supports, within the community to keep that patient at home and well. Staying healthy, staying home builds on that with in-reach into the emergency department and hospital wards, where patients who are at risk of preventable hospital admissions are identified and linked with that sort of service in the community. Our Partners in Recovery mental health initiative sees us working with 13 of the key mental health groups in our area to make sure those with the most complex chronic mental illness are well supported by health and social services. We have had some amazing care coordination experiences with the Institute for Urban Indigenous Health in much better integrating care for Aboriginal and Torres Strait Islanders in our community. And we have scores of clinical pathways across the continuum. Can see Brett here today, who's really been a leader in that, where we take best practice from the practice environment and general practice, link that across referral into the hospital, and then bring that wisdom and that support back into the practice when the patient returns to us. We have 12 general practice liaison officers who are working at the pain points in acute care to improve service integration across the interface, and all of this is only enabled by the strong partnership we have with our health and hospital service, particularly since the arrival of their new CEO 12 months ago. We are watching with great interest across the ditch a New Zealand model called alliance contracting. All district health boards and PHOs in New Zealand are now required to use this technique to build better integrated services. It comes from the New Zealand construction industry, which clearly has a very different culture to ours here, where multiple organisations recognise they can achieve much better things by working together on agreed pain gain contracts, where everyone shares a pre-agreed vision with the gains and losses based purely on the overall performance of all. And we have used that template for our primary health network commissioning over the past several years. We're also using that as a template for better integrated services with our local hospital network. And with the new changes announced through COAG, this will be a fantastic template to assist us with funds pooling for those wicked problems that need all of us lined up. Secret to alliance contracting in health in New Zealand, it's clinician-driven. Those people who are closest to the problem with their patients identify the opportunities and challenges. It's all of system, AMBOs, community services, residential aged care, whoever's needed to help solve the problem and be part of the vision is involved at the table. One system, one budget, one outcome. So we do have some exciting roadmaps available to us now. COAG has for the first time signalled the possibility of new governance and funding mechanisms which will remove a lot of the disincentives to move things forward. And the alignment of providers, end users and policymakers, particularly through the Healthcare Home Initiative, will provide a new culture where the people closest to the problem, the providers and end users of healthcare, will have a much more powerful statement through in the way health is delivered. In closing, tangible change is enormously challenging, but for millions of Australians, it is of paramount importance. The integration policy speak is favourable and the politics are compelling, but the necessary incentives are still currently absent and are absolutely critical to progress. And the heavy lifting will be by providers of care, both Commonwealth community funded and state health and hospital acute care funded, and will need significant ongoing cultural change and support to be sustainable. So let's not just move the deck chairs around. Let's be in an international gold medal team care performance. And finally, health is profound, it's powerful, and it's very personal, particularly for Australians with complex chronic disease. So let's not have them wait too much longer for a much better deal. Thank you.